I'm really honored to be here today and intimidated by following Dave, who's so forceful this morning. So he's woken everybody up for my talk. And I was asked to speak on Myeloma 101. So this is a very big topic. So I think I've been allotted, 5-6 hours there, Gabrielle? Gabrielle's already got his cards ready to give me 10-minute warnings. So without any further ado, I'd like to start. These are just my disclosures. So this is what I'd like to discuss today. I'm going to go through at least the first 4 points, and if I have time, I'll go over the fifth. Number 1, where does myeloma come from and how does it develop? Number 2, I'm going to go through the clinical manifestations of myeloma. Number 3, diagnostic testing. 4, because you'll hear lots about treatment, Frontline from Martha Luzada, and then Donna Reese will talk about relapse. I'm just going to talk about the principles and overview of treatment. And then if I have time, I'll, as my fifth item, talk about understanding clinical trial lingo. So number 1, where does myeloma come from and how does it develop? Well, we all know that myeloma is a disorder of plasma cells. Plasma cells are blood cells that normally derive from the inside of our bones, in the bone marrow. And these plasma cells normally have an immune function. And they're on the top there, you can see the little immunoglobulins or antibodies there are what are made by plasma cells. And the focus for those antibodies is to fight off any infectious organisms or any foreign invaders that attack the body. And they make a variety of different kinds of antibodies to try to target all the different invaders that could be seen. When one of the plasma cells kind of goes rogue, it can start to duplicate itself and then multiply. And so that initial cell will then develop into a clone of a whole bunch of very similar cells. So you can see on the bottom there, where they all make the same kind of antibody or immunoglobulin. So that's what we refer to as the monoclonal protein. So they're no longer making a variety of proteins, they're making just one because they all derive from an initial potential cell that's gone cancerous. So what makes a plasma cell turn into a cancerous myeloma cell? Well, we know there are probably multiple hits that are required. There's not just one event that suddenly turns a plasma cell malignant. We know that there's probably a background of genetic instability, and I'll talk about that a little bit later. Most patients with myeloma do have some genetic abnormalities that we can detect. There may be, on top of that then, a component of some kind of environmental exposure, maybe infection, inflammation. We've never really been able to consistently identify any factors like that precipitate myeloma. And then we know that there are microenvironmental factors. So what's the microenvironment? That's really the sort of supporting tissues in which the cancer cells are allowed to grow. So I'll talk a bit more about that in a minute as well. So genetic damage or instability, as I said, is seen with basically every patient. We can detect a lot of these abnormalities doing, you might have heard about FISH cytogenetics, and a variety of abnormalities can be detected. Chromosome deletions, translocations, you can get extra copies, and then you can have a whole multitude of abnormalities, and we refer to that as complex cytogenetics. If you look at the top figure here, that's an example of a deletion. So you know that we all have 23 sets or pairs of chromosomes that carry all of your genetic material. So if one chromosome in the top figure is missing a section, then that's called a deletion. And that deletion may carry some gene that's important, say in suppressing tumor growth. So a good example of a deletion that we always look for in myeloma is chromosome 17p deletion. That's chromosome 17 is missing part of the P part refers to the short arm of that chromosome. And that has a gene on it, that section that's missing has a gene called TP53, which is responsible for suppressing cancer growth, tumor growth. So if you're missing that, then you're not able to suppress tumor growth. So that's a genetic abnormality we see in about 5 to 10% of patients when they're first diagnosed. On the bottom is an example of a translocation. And again, you guys have probably heard about these. About half of all patients will have a translocation when they're first diagnosed, and or even earlier in the pre-myeloma stage, which we refer to as MGUS, or monoclonal gammopathy of unclear significance. So here, a translocation is when you have two different chromosomes, so A and B here, that exchange parts of their genetic material. So then suddenly you have genes that normally don't sit side by side on a chromosome, suddenly they're together, and that can lead to cancer growth. So a good example of a translocation is T414, so we refer to them as T brackets 4 semicolon 14, and then close brackets. And the 4 and the 14 refer to the two chromosomes that are exchanging material. So why is that important? Well, we know that genetic instability kind of studs the whole course of myeloma. I already mentioned that translocations and extra copies of chromosomes are very common early in disease course. And then as you progress, you do acquire other abnormalities. The 17p deletion I mentioned is more common as you advance with your disease. And then there are later other abnormalities, including mutations. And these are not just big deletions or switching of parts of gene segments, but mutations of genes, which we can't pick up normally with FISH, that we're starting to perform next generation sequencing for, so we can pick up actual genetic mutations of specific genes. And those can be acquired as you progress with your disease. So that's why you'll see us repeating a lot of the genetic testing, particularly with each new line of treatment that we start. I talked about the microenvironment before. This is just kind of a schematic of how the bone marrow looks, because again, plasma cells are bone marrow cells. If you take a plasma cell out, or a myeloma cell out, and you put it in a petri dish, it's not going to grow. It can't do anything because it needs all the supporting tissue and substances to grow. So you have to have kind of a conducive bone marrow microenvironment to grow your cancer further. So you can see from everything I've shown you that to try to attack and treat myeloma, there are so many different factors you have to keep in mind. The genetic abnormalities, what targets you may have there, what components you might have in your bone marrow environment that you want to target. So that's why treatment for myeloma is so complex, that just one treatment is unlikely to attack all the different hits that you've developed over time that has led to your myeloma. So I'm going to move on to the next section, which is the clinical picture for myeloma. And much of this you guys know. This is just some basic myeloma stats. How common is myeloma? It's not common. It is considered the second most common hematologic malignancy after non-Hodgkin's lymphoma, but it still only accounts for 1% of all cancers. It hits 6 per 100,000 persons, so that means about 2,000 people are diagnosed every year in Canada. However, people live years with myeloma potentially, so that means there are more people who are actually living with the disease, and that accounts for about 6,500 patients every year in Canada. Myeloma is a disease of older people, so the average age is 65 to 70, although we do have patients who are as young as in their 20s. And it does seem to have a bit of an ethnic predisposition, less common in Asians than in African Canadians, and a little bit of a predominance of men. So what are the signs and symptoms of myeloma? Well, you can kind of break them down into two big groups. One is related to the buildup of the cancer cells, And then the other is related to actual myeloma protein that they make. And the protein I referred to before as the antibody or immunoglobulin, and I'll discuss that a little more when I get into testing. The buildup of myeloma cancer cells can either be in the bone marrow, where the myeloma cells can proliferate and crowd out your normal blood cells. So you may end up with low red cells and anemia, low white cells, which help fight infection, low platelets. Platelets normally help you clot, so you may have predisposition to bleeding or bruising. Myeloma typically can attack the bones, cause bone pain, fractures, and simplistically release calcium into the blood. Outside of the bone marrow, on occasion, patients will have lumps of myeloma that grow. We refer to that as plasmacytomas, and they can develop in any site. And I'll talk a bit more about that later. And then down to the symptoms related to the myeloma protein. Again, I'll refer to this later, but can impact the kidneys and cause other damage. You've heard all about the crab symptoms. This is just a mnemonic for us to remember the big symptoms related to myeloma. C representing elevated calcium, R, renal or kidney dysfunction, A, anemia, which is based on low hemoglobin or red blood cells, and B, bone disease. So just a little bit about each. The calcium elevation in the blood is something we see usually when the people are first diagnosed, because they are, we usually are watching them closely enough down after they relapse or they're treated that we don't usually see the calcium build up to high levels later in their course. Because the calcium makes you lose a lot of fluid, people get dehydrated and they're really thirsty, they pee a lot. And it can also lead to other symptoms like confusion, stomach pains, and ultimately the dehydration can stress the kidneys and cause kidney failure. There are other causes of kidney failure as well. About half of all patients over the course of the disease will develop kidney dysfunction. And one of the most common reasons is the myeloma protein, part of it, the light chain part, can actually be excreted in large enough amounts in the urine that it blocks off the tubules in the kidneys. So this is a sort of a cut through a kidney where you can see, it's kind of like taking a tube and cutting it across and looking down upon it. You can see that inside the empty tubes, there's actually this pinkish material. They're supposed to be empty because that's where the urine flows through. And instead, they're occluded by this congealed myeloma protein. And that, as you can imagine, is going to block up your kidneys and cause dysfunction. So you need to flush that through and then get rid of that light chain so your kidneys can function. So that's one of the more common reasons besides high calcium. But, you know, myeloma patients can also develop kidney stones from high calcium. They're on potentially drugs that can cause dysfunction. And then there's a complication called amyloidosis, which I'll refer to a bit later, that can also attack the kidneys directly. Anemia is when the hemoglobin is low, and normal levels for women differ from men. So women are 120 to 160, men 130 to 160. So just to keep those in mind, it's not uncommon for patients to always run hemoglobins in the 90s or 100 range. There are many reasons, again, for anemia in myeloma. Again, about half of patients present with anemia when they're first diagnosed. And it can be either related to the inflammatory substances in the blood that suppress the development of red cells in the bone marrow, or you can have what's shown on this bone marrow picture here, where all those blue cells, those are plasma cells, those are myeloma cells. They're just like crowding out the bone marrow. So there's no space for your normal bone marrow to make blood. So when you're anemic, again, red cells carry oxygen, so you will feel fatigued, weak, short of breath, and you may be pale. Bone disease. So 80% of myeloma patients will develop some kind of bone disease. And these are some x-rays. Well, the middle one is an MRI to show you what it looks like. Typically, the bone disease in myeloma is either little holes in the bones, so it eats away at the bones, and you'll hear us refer to lytic lesions. Lytic just means we're making holes. Some cancers actually build bone deposits, so it's not lytic, it's blastic. But for us, we see holes. So you can see it on the left is an x-ray of a skull. You can see those little dark marks. Well, anyways, you can see them. The dark marks on the skull that are not white, those are the lytic lesions. In the middle, this is the spine. It's an MRI where you can see the vertebrae should normally, there's one in the middle that's kind of a good height, and then you can see the one below that is blacked out because it's filled with tumor. And the one above the normal one actually has been squished already, so that's a compression fracture when the bone is weak. So those are different manifestations of bone disease in the spine. And then you can see on the right x-ray, that's femur or your thigh bone, and you can see a big lesion right there. This is something we worry about because you walk on this. And if this is making that piece of bone weak, then it could break when you put weight on it. So this would be something an orthopedic surgeon would want to look at to repair. So these are things that we look for often with doing a skeletal survey, which is x-rays of virtually every bone in your body. We also can see nerve damage. There are a variety of mechanisms behind that as well. One of them is if the myeloma is creating a lump of a tumor or even just the bone fragments from your spine that are pushing out against the spinal cord. You can see here, this is an MRI again with the vertebrae in the gray, and then the white part is your spinal cord, and you can see parts where the tumors are coming out of the vertebrae and indenting the spinal cord. So that can lead to back pain, numbness, tingling in your feet, bowel bladder problems. So we're always on the lookout for that. And then the myeloma protein also can damage the nerves directly. This is not very common, less than 10% of patients, but it can then cause the numbness and tingling in fingers and feet. It's kind of a symmetric neuropathy. Very occasionally, so certainly less than 10% of patients will have such high levels of protein that their blood will be very viscous or thick. And the picture on the left just shows two tubes. The one on the right is just the normal plasma. This is the clear part of your blood without the cells, which just runs down to the bottom of the tube. But on the left, it's so thick, it's like gel, and it's just stuck to the side of the tube. That's when your blood is very high due to high myeloma protein levels. And you can imagine what that's doing inside your blood vessels. If it's sludging to your head, then you may get headaches, confusion, visual changes. If it's sludging to your lungs, you may be short of breath. And it can predispose you to bleeding or clotting. And then there are a variety of reasons why patients will be prone to infections. Your immune system is weakened for many reasons. It could be the myeloma itself, where your normal antibody levels are low, because your myeloma protein is elevated. But also a lot of the chemotherapy and other new treatments we use can suppress your immune system. So common infections are pneumonia, shingles, which is a viral infection, urine infections, etc. So I mentioned amyloidosis a bit. This is a talk in and of itself. You're going to hear from Chris Venner this afternoon, I think, or tomorrow. And this is when part of the myeloma protein deposits in an unusual fashion in different organs. It kind of deposits in this fibrillar pattern. So you can see on the right, the image is it's a special kind of radiograph. It's an electron microscope where you can look down into really microscopic levels of the protein, and you can see that it's laying down in these fibrils. When that it gets laid down in heart or kidneys, it can cause significant dysfunction. And that can be either a disorder by itself or it can be associated with myeloma. So we are always on the lookout for this complication because it does significantly change how we manage the disease. Okay, so that was a whirlwind through the clinical picture for myeloma. I'm going to move on to diagnostic testing and monitoring for myeloma. So this on this slide shows you everything we do when we're looking for myeloma right off the bat. No matter what, if we think you have myeloma, we're just going to order these things. They're pretty standard. So we do blood tests. We look at your hemoglobin, white cells, platelets. Of course, we look at your kidneys, which is shown in a test called the creatinine. We look at your calcium level, as mentioned. We'll do protein studies, and I'll talk about that in a bit more detail. And then there are some tests that don't help us diagnose but are useful for staging or prognosis. The beta-2 microglobulin and albumin levels, those are all in the blood. To check for the protein, we'll also do a 24-hour urine collection. I know you guys all love that. We give you this big jug, you take it home, carry it on the subway with you, and we ask you not to keep it in your fridge because that's kind of gross. So the reason why we do 24-hour urine is because the amount of urine you pee out, or protein you pee out that's related to myeloma is very erratic through the days, so we want to capture the whole picture over one day. If we just did a single test in like 2 o'clock in the afternoon, we might miss the accurate amount. When we're looking for the protein in the urine, we actually call it something else. We refer to it as Bence-Jones protein. That's the same as the light chain of your myeloma. And I'll get into that with testing. X-rays, the skeletal survey I mentioned already, also referred to as a metastatic survey at some centers. It's essentially like 30 different images of your bones, your skull, all the long bones, your vertebrae. It just gives us a good snapshot of where you have bone lesions. However, if you're really having pain, say in your back, we will frequently do an MRI in that area or CT scan just to focus on the details there. An MRI will pick up whether there's a lump of soft tissue myeloma, whereas an X-ray will only show you bones. And then on occasion, some of you may have had PET scans. We don't do them routinely, but they help us identify areas of activity. And in some patients where there isn't much of a protein to follow, that may be helpful as a monitoring tool. And then I already mentioned the bone marrow. And sometimes we will do biopsies of other tumors if we're not sure what it is or if we're just trying to confirm the diagnosis. So I've already mentioned many times this monoclonal protein, and typically it looks like this. This is an antibody. Remember, this is made by plasma cells. The antibody is made up of the two long parts that are joined in the middle, represents the heavy chain, and then there are short segments attached to each heavy chain called a light chain. So there are various types of heavy chains. IgG is the most common type that is made in myeloma. About 60% of patients have an IgG. About 20% make an IgA protein, and then the rest, IgD, E, and M, are really quite uncommon. They all comprise only about 1% of myelomas. But there are patients also, and then the heavy chains can either be attached to a kappa or lambda light chain. About 10 to 15%, though, will just make the light chain part. And that impacts how we monitor. So just remember, you could just make lambda light chains and not make this monoclonal protein, or what we refer sometimes as an intact monoclonal protein. And then rarely, probably no more than 1 or 2% of patients make nothing, and we call them non-secretory. And those patients are really tough to follow because there's no test that we can look at in the blood or the urine that will easily help us monitor their disease. So the first test we do, and I'm not going to get into detail here, but you will all have heard about some of these things, serum or urine protein electropheresis. We take the patient's blood and we essentially separate out the proteins in the blood. And so you see something on the left, thanks Dave, is what we end up with. It's a tracing of the proteins. You can see the big spike on the left image. That represents your albumin, because you have lots of albumin in your blood. It's a type of protein. And then all the other spikes are like alpha-1, alpha-2, beta, gamma regions. So there's like different kinds of proteins that fall into these different, lumps. However, if you have myeloma, remember that cancer cell that went rogue and duplicated itself and kept making other clones of itself will all make the same protein, that monoclonal spike or monoclonal protein. And so that protein will be detected as this M spike. So it's clearly different from what you see on the left in the normal electropheresis. So that's the reason why you'll hear us referring to this as a spike. It's because that's how it looks on this electropheresis. It really just represents the quantification of the protein. We don't quite know what it is when we look at this, so we do have to do other tests, and you might have heard about immunofixation to just tell us what it is, like is it IgG kappa or is it an IgA lambda, like I talked about. But this is the test we do to identify the protein first and to monitor down the road, because it will quantitate the amount of protein. But remember I said that some people only make light chains, and then a lot of people, 90-some% of patients, will also make some free light chains as well. So it's useful to be able to measure just the light chain, the small section of the protein, rather than the whole antibody. So we have this assay called the free light chain assay. And you can recognize on the left is kind of what I showed you before, is an intact immunoglobulin or antibody with the heavy chains and the light chains attached. The red part of the light chain that's attached to the protein is hidden. It's kind of hidden from the surface, but when the light chain is loose by itself, that red part is available and can be picked up with this assay. So we'll then also, we routinely check free light chains on every patient as well as the monoclonal protein. And it can be a very useful test to monitor patients, particularly in those who only make a light chain. So as I mentioned, because not everyone makes a protein, to make the diagnosis of myeloma, you do not need to have a monoclonal protein. It makes it easy for us, but you don't have to have it. What you do need are the criteria below. You need to have at least 10% plasma cells or myeloma cells in your bone marrow. People who don't have myeloma typically have about 1% plasma cells. Remember, plasma cells are normal immune cells in your bone marrow, so we have some, but no more than 1%. So you either have to have more than 10%, or you have to have a lump of myeloma somewhere that we biopsied and it shows there's a clump of the plasma cells. So that's a plasmacytoma. Or you need to have one of the following. So these are all markers that you have active myeloma need to be treated. So we already talked about the CRAB symptoms: calcium, renal failure, anemia, bone disease. But there are also now 3 extra biomarkers that we test for. Even if you feel well and you don't have CRAB symptoms, we're still going to look for this because they predict that you're going to need treatment sooner than later. So we don't wait until you have anemia. We don't wait until your kidneys go off. We start treating you based on these markers. And it's not important to really know what they are, except that it's changed how we follow people a little bit. And it does mean that we test people with MRIs a little more frequently than before, because it's much more sensitive than the X-rays at picking up subtle bone lesions. So you've seen this already, but this is what the bone marrow looks like with all these big blue cells being plasma cells. They're really dark and blue because they make a lot of protein, and that stains that color, whereas all the kind of they look kind of orangey here, orangey pinky cells in the back, those are red blood cells. They don't have very much protein, so they don't stain blue. The bone marrow, besides identifying the plasma cells and allowing us to quantitate them, so the pathologist will say it's 1%, 10%, 15%, or 90%. It also allows us to do some genetic testing. I talked about the genetic abnormalities we see. We typically do a test that's called FISH. It's an acronym for fluorescence in situ hybridization. It's a mouthful to say that we can take different probes to pick out the common abnormalities we expect and look for them. And so I've listed the ones that we do at Princess Margaret and are probably done at many centers across Canada. I've already mentioned 17p deletion and the translocation 414. So the T brackets bit are translocations. People ask a lot about staging of myeloma, and I always have to explain that it's not the same as staging for lung cancer, where if you have it in one spot, that's stage 1, and stage 2 is going to other parts of the body. In myeloma, it's a blood cancer, so the cancer is pretty much everywhere in your system because blood goes everywhere. So staging for us is really using a variety of different blood tests in conjunction with your genetic abnormalities. And when we put that all together, it helps us give a little bit of an idea of well, primarily your progression-free survival, or basically the duration of time before your disease starts to grow again. So it's helpful, but it doesn't usually necessarily dictate the treatment, and we don't, we tend not to spend a lot of time on the staging, but it's here if you are interested. Monitoring of myeloma, I already discussed, is helpful if you do have a monoclonal protein. This is how it looks on our screens at Princess Margaret. We trend things, and you can see that we do the M protein quantification, which is in the column with that red arrow. And you can see that we measure all the common immunoglobulins or antibodies, the IgA, IgG, and IgM. The IgA is very high here, which correlates that with this patient having a monoclonal protein that's IgG subtype. And you can see how when we trend things, we can see that patients are dropping their M protein with treatment in this particular patient, going down from a high of 58 grams per liter down to 9.3. So that represents a patient who's responding to treatment. So that's what we're looking at, one of many things we look at when we're monitoring disease. Remember, most people make light chains also, but some people only make light chains. So we do the same with the light chains. So we'll trend it. So you can see that this patient started off with a light chain of over 4,000, and it's come down. We likewise look at the other light chain that's not affected, because sometimes it's suppressed and it will start coming up. So we sort of start to see this balancing out of the two. All these numbers are useful for us to monitor your disease. So that was a whirlwind through testing and monitoring. And now, again, I just want to iterate that I'm just going to talk about the principles and overview of treatment, because it's far too much to discuss in terms of details. So we know that myeloma to date is not curable. We've made lots of strides in recent years, but we still can't say we cure everyone. So we only treat people if they have symptoms. So we talked about the Crab symptoms, those 3 biomarkers I mentioned. You may not have symptoms, but those 3 do indicate you're going to become active sooner than later. So we'll take those 2 and sort of lump you in as symptomatic and start treatment. So if you don't have symptoms, we refer to you as smoldering myeloma. So you have myeloma, you have at least 10% plasma cells in your bone marrow, and you've got some at least 10%, and then we call you smoldering. But if you don't have any Crab symptoms or those biomarkers, we just watch and wait. If you do become symptomatic or have any of those abnormalities arise, then our standard approach is to treat you with multiple agents. So our colleagues always laugh. Our colleagues who don't treat myeloma laugh at us because they say, well, you guys throw the kitchen sink at your patients. Well, there's a reason for that. This is a multiple myeloma. There are multiple clones. On average, at diagnosis, people have between 5 to 7 different clones that derive from 5 to 7 cells that went rogue. So we want to try to attack all those different clones. Those clones may differ in terms of disease sensitivity to drugs. So that's why we use multiple drugs, and why we also continue to treat patients, because we aren't curing anyone, so we're trying to keep all those clones suppressed for a long period. So you'll see that we don't usually let up on therapy for you Occasionally after a transplant, we might give you a short break, but most people are even still on maintenance. I'm not going to focus much on individual drugs, but I think it is important to at least mention our backbone drugs, which are bortezomib, also known as Velcade, or lenalidomide, also known as Revlimid. These are our backbone drugs that we use from the get-go. Bortezomib is proteasome inhibitor. Lenalidomide is an immunomodulatory drug, also known as an IMiD. So just so you're familiar with those terms, because we are starting to see newer versions of these drugs. Proteasome inhibitors like ixazomib and carfilzomib are now here. Other IMiDs like pomalidomide also in common usage now. So it is important for us as physicians, as well as you guys, to understand the side effects of each and how they're administered, because they really do play into how we choose treatment for any individual. So bortezomib is given as an injection into the skin. Usually you come once a week. So again, might be hard for people who live far away from a center where it's administered. Side effects, besides fatigue and diarrhea, which are usually manageable, the one that often has to be taken into consideration when we choose treatment is the fact that it can cause some nerve damage, numbness, tingling in fingers and feet. So that may impact, if you already have some nerve damage from maybe your myeloma already, that may impact whether we can safely use this drug. And then bortezomib makes you prone to getting shingles, a viral illness, so that patients are frequently on, are usually on an antiviral therapy. Lenalidomide, or an IMiD, is a pill or a capsule, so it's easier in some respects to take. But it does drop your blood counts more, so it needs close monitoring. And it causes or predisposes you to getting blood clots. So most of you will be familiar that you need to be on some kind of anticoagulant or aspirin when you're taking it. And there is a concern about it causing some damage that leads to the risk of second malignancies, like many different treatments we use, particularly even the melphalan we use in transplant. So when we first see a patient, we decide they need treatment. They're symptomatic. What do? Our first decision point is this patient someone we would move to transplant or not transplant? So those patients not eligible on the left generally are those who are older. So many centers will use a cutoff of about 70, but it varies from center to center. There's no hard cutoff. If patients are unfit with many health problems, we feel that the transplant, which is one big bang of treatment, may be hard to tolerate, so they may be put into the non-eligible category. And those patients, our standard treatments currently include either RD, which is lenalidomide and dexamethasone, or VMP, which is bortezomib-based treatment. So again, you're seeing our standard backbone drug combinations. Soon you'll hear more about daratumumab, a monoclonal antibody, being added to some of these regimens. But currently, this is what we have available. And Martha's going to talk more about frontline treatment. So this generally keeps your disease stable for a couple of years before you do need more treatment. If you're younger, under the age of 70 or 65, and you're fit and healthy, you may go the transplant route, where you usually start off with some kind of preparatory chemo, and our standard one is called Cybor-D. The BOR part, B-O-R, is the Velcade. So again, you're seeing our backbone drug thrown in here. And then we go on to transplant, and we typically, many centers do or do not offer maintenance treatment afterwards to hold the myeloma quiet. And this can keep your disease quiet for 4 or 5 years. That's just on average. So this is kind of the process of transplant, and it's autologous because we use the patient's own stem cells. You may hear about allogeneic transplants where we use stem cells from a brother or sister or even a parent. That we do not do routinely in myeloma. So the process of an autologous transplant is patients get that preparatory chemo, the Cybor-D I mentioned, to kind of get people feeling better, improve their kidney function, improve their hemoglobins. And then we do a stem cell mobilization and collection. So there are various ways of doing this, but generally we give you some kind of medication to get your stem cells or your mother cells that grow bone marrow to come out into the blood instead of just sitting in the bone marrow. And then we collect it with a machine. And we collect it and put it in a bag. We freeze those stem cells temporarily until you're ready for your transplant. And when you get your transplant, you get high doses of chemo, which just kill off your bone marrow. You can't live without bone marrow, so we need to give those stem cells back to you that we've frozen. So we thaw them out and we infuse them back in, and we just infuse them through an intravenous, and they circulate around your system until they lodge in your bone marrow and regrow. So that whole acute transplant part takes a couple of weeks, but you can imagine all the lead up to that takes many months, and recovery is generally at least 3 months afterwards. So it's a better part of a year to get through this whole process. At Princess Margaret, we perform about 200 and some of these transplants for myeloma every year. So that's the front line in a nutshell. What do we do when the myeloma comes back? Because it will. We tell patients this is not a cure. We are trying to keep your disease quiet, but when it does come back, what are your options? And often we can group them into 3 big categories. One is you can repeat a stem cell transplant. Not every center does that, but you can. We at Princess Margaret do reserve a second set for patients if they need it later. We can move towards clinical trials, and this provides access to new drugs and improves on standard therapy, but can mean there's more commitment to coming here, extra time, visits, testing. And then there are standard treatments, and I am not going to talk about the individual drugs, but we are very fortunate in myeloma to have in the last 10 years a number of new drugs like pomalidomide, daratumumab, carfilzomib that are now approved with and available for the use of treatment of myeloma patients. And thanks very much to Myeloma Canada and helping to get these drugs available here. So how to choose your next treatment? So I've already mentioned that there are many factors that we take into account. Every time we see somebody who's now progressing and we have to think about switching treatments, we think about all these characteristics. About the drug characteristics. Is it an oral drug? Is it intravenous, subcutaneous injections into the skin? Patients have preferences over those. Side effects, if you already have bad nerve pain, do you really want to go on a drug that may make that worse? If your blood counts are low, then it may be hard to give you a drug that is known to cause some suppression of your blood counts. And I hate to say this, but funding or access to drugs does play a big part into how we choose treatments. Patient characteristics, like the medical problems they may have, one of the big ones is whether your kidneys are working well, because some of these drugs largely rely on you to pee the drug out so that you don't build up toxic levels. Where you live, ease of travel, your preference, all need to be taken into account. And then lastly, your disease characteristics. So we do look at your risk status, largely based on FISH genetics, but there's some clinical parameters we'll look at too that will help us decide which treatments we'll go to next. Sometimes we'll go earlier to an experimental treatment if we think you're not going to respond to standard treatment. And then also very importantly is what treatment have you had already and how well did you respond to it? And are you growing your myeloma or progressing on it? Because that all comes into play for what we're going to choose next for you. So I'm going to just spend the last little bit on supportive care. There are key, myeloma has lots of, unfortunately, complications that require ongoing care. Bone disease is one big one because it causes pain and fractures, and it can be really debilitating. So you'll all probably have been on a bisphosphonate, either zoledronate, pamidronate, even maybe clodronate. These drugs help you decrease bone loss, so we use them routinely. Certainly when you're first diagnosed, we use them routinely, and then we may use them intermittently down relapse. We also will radiate spots because myeloma is a very radiosensitive cancer. So if you've got a really painful area somewhere, sometimes one shot of radiation to that one spot will help deal with it. And then we'll use things like kyphoplasty or vertebroplasty to help with compression fractures in your spine. So this is a picture on the right where kyphoplasty is when one of your vertebrae have squished, and it can be very painful. It also can make you kind of not aligned anymore with your back. So they can, our interventional radiologist can stick a needle in and blow up a balloon. It opens up that vertebrae. They pull out the balloon. Now you have this cavity there, and they fill it with bone cement. So they can realign your back. They can, it can instantly relieve your pain as well if it's very isolated to one or two sites. We put, once patients are have their disease under control, we will ask them to go on calcium and vitamin D to try to keep their bone health optimal. And then because bones hurt, pain management is really critical. I'm not going to go into detail there, except that we ask people generally to avoid anti-inflammatories because they can cause some problems with your kidneys. Anemia, low hemoglobin, is present in half of patients at diagnosis, and many will need blood transfusions throughout their treatment. So you'll see us using a lot of EPREX or Aranesp. These are drugs that can stimulate blood growth. And I already mentioned patients are prone to infections. We screen everybody routinely for TB and hepatitis B before we start treatment. We give a lot of preventive antibiotics based on what treatment you're on. We do a lot of vaccinations. Most recently, we encouraged the Shingrix. It's a vaccine against shingles. Previously, the shingles vaccine was a live vaccine. We asked people not to take it, but this one can be given because it's a dead vaccine. And then occasionally people with severe recurrent infections might be because their normal antibody levels are suppressed. So we will use infusions of immunoglobulins. So I'm going to ask Dave now, because this is my last section. It says 2, but it's supposed to be 5. Understanding clinical trial lingo, whether I should skip that, because Gabrielle's like flashing all these cards at me that I have. I can do this, or I could skip, and do we have time for questions after each, or are we leaving it for the panel?
Well, right now we have 10 minutes available for questions. How long will it take you to go through the clinical trial lingo?
5 minutes?
Why don't you do that? Then we'll have time for
Okay.
maybe a couple of questions.
Okay.
And again, please keep in mind any further questions you may have. Put them down on your cue cards. We have an hour starting at 11:30 for questions from Dr. Chen and some of the other speakers.
Okay.
Thank you.
All right. So, so take it easy, Gabrielle. I'm going to stay on time. So these are the, I'm just giving you a overview of trials. There are generally 3 and maybe 4 different types of trials that we may offer to you at any point in your disease, phase 1, 2, and 3. Phase 1 trials are, and all drugs, new agents, have to go through this process of going through phase 1, 2, 3 before they become standard of care and are approved and then ultimately funded for treatment. So we always encourage people to be participants in any of these trials. Phase 1 trials are small. They're usually with novel treatments that haven't been used in trials much. Their goal is to determine how safe the drug is and often to identify an optimal dose. So we're just trying to determine toxicities because they haven't been used very often. They're often just done in a single center. You'll see different dose levels. And the trials often last months to maybe a year or 2, but they're not very long-lasting trials. Once they've gone through that and we've identified a dose, they go to phase 2. These are bigger trials, and the goal with a phase 2 is just to see, does it work? We're not comparing it to anything, we just want to know if it works. These trials are longer because the endpoint for how it works may be maybe not just response rate, but it may be how long does it last in a response. And then when that drug has shown some efficacy, we knew that it was safe from phase 1, we know the right dose, then we want to compare it to what we're normally doing to see are we better. And so that's a phase 3. It's usually, we call them also randomized controlled trials, where we compare to the control, which is our standard of care. And they're randomly put in those two groups. And this is just an example of a schema of a trial, because you might see these. And all it means is that patients are put on trial at the top, then they get randomized. Randomized means you're randomly placed in one or the other group. And then there's always a control or standard arm, then there's an experimental arm. This is a phase 3 trial. Sometimes they're blinded or unblinded. Unblinded means everyone knows what treatment you're on. If it's blinded, you might be on an arm where you're getting a drug, but we're not sure whether it's this drug or that drug. Okay, so that eliminates the risk that you might be biased, because if you know you're on the treatment, you might interpret some of your symptoms, or physicians will interpret differently. And then the endpoints, you'll hear us talking a lot about progression-free survival and overall survival. And I just want to show you a curve, because whenever people come talk to you guys, we show a lot of curves, and patients ask, what the heck do these mean? So this is a standard progression-free survival. And it takes patients on the y-axis here. It's like starts at 100% of patients. On the x-axis, the longitudinal one, it's time. So over time, what happens when you've been treated on whatever you're testing? How long does it take before half of the patients have actually progressed on that treatment? And so you'll see the 50% line is the half mark. So on this curve represents two different treatments, green and treatment A and the purple treatment B. And by at 50% mark, 50% of patients have progressed on treatment B by 7 months, where 50% have progressed by 12 months. So that represents a significant improvement in duration of response. So that's how we interpret these things. That's often a key endpoint in trials for us. So there we go. I did that in 5 minutes. So in summary, myeloma is a complex disease from both clinical and genetic perspectives. Diagnosis and treatment, we do try to personalize to the patient as well as the disease, and then always consider clinical trials. So talk to your doctor. This talk does not replace your physician. So thank you.
Wow, Dr. Chen. So we do have time for 1 or 2 questions. Does anybody have a question? Yes, ma'am. Just hang on, wait for the mic, please.
Hi. Does current research show that it is familial?
Yeah, so that's a good question. There are pockets of families that do have increased risk of myeloma, where we see more than one person with myeloma. And it's still not entirely clear whether there's some kind of environmental exposure or if they share some kind of genetic instability. I think it's fair to say there probably is some familial component. It's not strong enough that we tell people to go screen their family members, because more often than not, we'll find nothing. Okay, and most of the genetic abnormalities or instability that I referred to appear to be acquired. Like you get it with time. It's not born. You're not necessarily born with it. Although to be truthful, we're not testing for all this in children. This is a disease in older patients. So it's not a very clear answer to your question, but that's all I have to say.
Okay, one more question.
Yeah. Oh, sure.
Okay, please.
Okay, about the Shingrix vaccination, because I've heard like some doctors think because it's not medically recommended, there's no medical information confirming that it's good to have it. Nothing says it's not good to have it, so because it's like in a gray zone, they don't recommend it, or?
Well, we do recommend it. I mean,
Okay,
there's efficacy.
you do? Okay.
There are data that show that it's effective
Okay.
in preventing shingles. And one of the the reasons why we do recommend it, if, again, there's an extra cost to it, it's not automatically covered by OHIP. The reason why we do encourage it is because a lot of our treatments predispose to shingles, right? So shingles is, and we are constantly using drugs like acyclovir, famciclovir as antivirus prevention. They're not 100% protective. Neither is the Shingrix, but you may as well try to do what you can to prevent getting shingles.
Okay, which data confirms this? Like if I want to talk with my doctor, say, check out this data, is there a data he can look at? I don't know.
I wouldn't be able to, off the top of my head, give you all the references, but I could look it up for you, or I'm sure your doctor could find it. It's all
okay.
Available.
Thank you very much.
Okay,
Oh,
ma'am.
yeah, these guys. What? Sorry, you guys. These guys will do it.
Oh, great.
Thank you.
Thank you.
Yeah, if you have access to medical databases, we can pull up the data for you. But if that's a common question, that's something we should be able to provide to you guys.
Yes. And one last question there, back by Jesse in the back.
Just wanted to know, when monitoring like the protein levels, would it be common to see like the M protein go down but the free light chain go up, or vice versa?
Yeah, so remember I said that myeloma is multiple clones. So it's possible that one clone is mostly making the M protein part, and then another clone is more of a light chain. Sometimes we do see things are quiet. The patient had an M spike before and it's down, and just suddenly the free light chain starts to grow out of keeping with the other M spike. And we call that free light chain escape. And that does represent a separate clone that's growing. So that's why we routinely test all those every time. Even if you don't have excess light chain, we just check it anyways in case the next clone that's coming out is going to have primarily the light chain expressing. So yes, you can see that, but usually when you're first diagnosed or early on, a lot of your disease is being suppressed simultaneously. So much more often we'll see everything come down at the same time, the M spike, the light chain. Remembering that the light chains are really erratic, so if you're testing a lot, sometimes it'll be up and down. It's dependent on your kidney function, so if you're a little bit dry and a bit dehydrated, your kidneys are a little bit off this week, your light chain might bounce around a lot more than your M spike. So I always discourage patients from focusing on any one value, because if you repeat it again in a week, it often has come down again.
Okay, so please join me in thanking Dr. Chen for a tremendous and very comprehensive presentation.